Okay, I think it's recording. I'm back in plenary session, video edition, joined via Zoom by Manni Mohyuddin. Manni is a great asset to the field of multiple myeloma. He is graduating from the University of Kansas Hematology Oncology Fellowship. He's starting a faculty job at Utah. He's going to focus on multiple myeloma, and he's going to make it great again. Manni, it's great to see you. It's great to see you.
Pleasure's mine. Thank you.
Boy, it was a few months ago, I think, maybe even about a year ago, that I think you reached out to me. You had followed the podcast. One of the few people who've read the book *Malignant*.
Yep.
Few people, um, and you said, let's take some of these ideas and let's focus on myeloma. Let's spin them out a little bit. And we've been working on stuff. We've been staying busy.
Of course.
And we're going to talk about some of that. But I wonder if you might talk about, I don't know, it sounds like some of these ideas struck a chord with you, but you'd always been feeling this way. So I wonder if you might talk about, your feelings in oncology.
So, you know, so going through residency, there's a lot of hype. And like until you start oncology fellowship, you don't know what is true and what isn't true. So like I came with these expectations that, we've like made dramatic advances in cancer, and we have in some ways, but like I came on a high, like, that all these targeted treatments are doing great. Like immunotherapy is changing the field for like every single cancer. And like that's what I would tell when I was interviewing for fellowship. That's what I would tell people. And now I'm like, wow, I was naive. And then there was this big discord when I started fellowship, and I saw all the death and the suffering and the hype. And then it really, like, I got very reflective about all of that. And then reading your book, and then reading some other books as well, like Azra Raza's book, The First Cell. Like it really struck with me, and it told me about, there's a lot of things we're doing wrong. And like I think that we're just like so mesmerized by, novel mechanism of action, or just a novel pathway. And like there's less focus on like quality of life, less focus on whether it's actually making people live longer. So yeah, so like when I heard the podcast and then when I read the book, I was like, wow, this does resonate with me. And then yeah, like I saw that you and then Aaron Goodman, for that matter, you guys were tweeting about like the same things that I was thinking about. So I was like, wow, we should all get together and work on a few projects. So I'm glad I reached out. I mean, and I joined Twitter like back in June, and I think this is the only good thing that's come out of Twitter.
I would say the same too.
It's been all regrets, that, and I guess you sort of find out if there's something new. But other than that, yeah, I do regret, because otherwise I've been off social media and I've been a happier person since I've been off. But yeah, no, that's yeah, there was just a big feeling of disillusionment at how much hype there is, and like what our priorities are, and how we're so vulnerable to being swayed by these like big fancy words that we hear. So yeah, it resonated with me.
That's nice of you to say. I also like Azra Raza and her work. I think the reason I like her is I think we agree very much on what the problem is, and then where we disagree is how to solve it. But that's a fair disagreement. I think totally fair.
Yeah.
And I'm also a big fan of Aaron Goodman. He came out initially guns blazing, and I was like, "Oh, I've missed this passion and energy. I hadn't seen it in a few years." Just excoriating selinexor, which I think is legitimately a drug that legitimately deserves criticism. And now he's pivoted rather gracefully to being sort of the great educator. I think he is self-called Papa Haem, and he's got some really nice educational modules. But yeah, the three of us have worked on some stuff. So why don't we talk about this? I can't release this until the paper drops, but this paper is coming, and it's coming in the Lancet Hematology. That's an AE for you. It's AE Hematology. It's the proper spelling. So I wonder if you might walk us through this paper. What did we look at?
For sure. So I guess the brief background to this paper is that, so as a fellow, I would see all of these like 3 drug versus 2 drug trials, and I would ask like faculty members, and they'd be like, oh, so 2 drugs were the standard of care at the time this trial was designed, and I was like, okay. And then I saw Aaron Goodman and you tweeting about this, right, where like Aaron had clearly delineated when the results for a certain trial came out, and then that same control arm was used a few months later for another trial. So I was like, we should systematically put this to test. So what we did in this study is that we did a systematic review. So we looked through the last 10 years of myeloma randomized control trials in the United States. And we chose to focus on the United States because, as you know quite well, the standard of care varies differently in different countries. And we can talk about how that's manipulated. But, so 3 drugs is the standard of care now in the US for myeloma, for newly diagnosed and for relapse refractory. So we looked at all trials in the US, and we found about 49 discrete randomized control trials, some of which are resulted, some of which are still enrolling. And then what we did is that we assessed the quality of the control arm. Now, this is similar to some of the work that you've done previously, which the one that was published in JAMA Oncology. And what we looked at, and we used a rather simple criteria. We used that, has the control arm been previously beaten in a randomized control trial? And if the control arm had been beaten and that was known prior to the start of enrollment of the trial, that was recorded separately. Then we also found, recorded whether, so a trial has already started enrolling, and then a few months down the road, the control arm is shown to be inferior in another trial. We also separately recorded all the instances where that happened.
Yes. Okay. So what you're saying is, control arm, is it the best available standard of care? It had to run in the USA. Right. And you're separating 2 things: things we knew were inadequate when we started the trial, and things we knew that were inadequate sometime during the trial. That's what you're looking at.
Yep.
Okay. I think it's fascinating. And I guess the only thing I will add for the listeners to realize is, you're right. Talal Halal, who is faculty now in Mississippi, we looked at this kind of broadly in HemeOncology. We didn't take this added step that you're taking, which is, during the course of the trial, did you have new information? And the reason that matters is, you can imagine you're randomizing people 1-to-1, then 5 months into the trial, you get some new information that your control arm is actually inferior to some other standard of care. And immediately in your practice, you're probably pivoting. You're no longer giving that 2-drug combo. You're pivoting to a 3-drug combo, for instance, and except for the patients you're enrolling on the study, because the study is not putting in a protocol amendment to switch the control arm. Now, some people might push back and they'll say, well, I can't expect everyone to do these protocol amendments. But the flip side is, well, what if this were your mother or father? Would you really want them to get that control arm when it is inferior to something else? And that really ought to be the control arm of the study. And the other thing I'd say is, well, your trial is not going to answer a relevant question by the time it results, because the control arm is no longer that. So that's the way I would push back on it. Okay, why don't you unpack these 2 things? What you found, what were the results?
Sure. So amongst those 49 trials, so 7 of those trials, the control arm was clearly inferior even before the trial had started. And I guess one of the more egregious examples of this is the Boston trial, which we talked about extensively, with the selinexor Vortex versus Vortex, where you had almost 2 years where a doublet, and I'm not even talking a triplet, a doublet had shown superiority to bortezomib dexamethasone. And indeed, that trial has now gone on to show an overall survival benefit as well. But that is a pretty egregious example. But there were several other examples as well, and there are some examples where Pomdex has been beaten up repeatedly, and it continues to be a stepping stone for all trials. In all new myeloma drugs have to stomp upon Pomdex before. So we found 7 trials, and sometimes it was a matter of a few months, but sometimes it was years. And then we found an additional 9 trials where the control arm, was found to be inferior during enrollment. And in our discussion, we give a nuanced, we try to be balanced about it, because it is complicated. It's not that easy, changing your protocol midway. But it should be easier, right? We should make it easier. We should serve our patients better. And if it's just a matter of a few months, then that's fine. But there are a few examples where, let's say the study that compared pembrolizumab, lenalidomide, and dexamethasone dexamethasone versus lenalidomide and dexamethasone. Now, technically,
Bellini, is that Bellini?
no. So that's the keynote. I think it's 185. Bellini is the one
Oh,
where.
it's venetoclax. It's venetoclax, obviously. Okay.
So this study, it started enrolling like 2 months after SWOG 077 resulted. Okay.
Yeah.
Now SWOG 077 is, it's a pretty famous trial. That's where
Of
VRD.
course. VRD versus RD, the famous cooperative group study. Yeah.
Right. So there are two things, right? So yes, on paper, yeah, like at the time, you started enrollment, like, yes, SWOG 077 had not resulted yet, but everybody was still using a triplet. Like, even though we didn't have official results, like,
Yeah.
if you look at registry data, like people were using triplets.
Yeah.
And then, so 2 months later, SWOG 077 results, but the trial continues enrollment.
Yeah.
For like 90% of the time that the trial was enrolling, it was enrolling onto an inferior control arm. And then, as Aaron Goodman, I love his tweets, he pointed out very clearly on Twitter that this was a trial where the control arm was hurt and the intervention arm was hurt.
I was about to say, they're hurt even more. Yeah. It's the only trial where both arms were inferior to the standard of care.
You couldn't even beat Lendex. And it just goes to show that, like there's.
Wait, should we explain that? It's because the keynote study was halted for futility, increased death.
That's correct. Yes. So yeah, both in the newly diagnosed and relapsed refractory setting, pembrolizumab did not show a benefit, and indeed, like there was more toxicities. So it just goes to show that there's a need for improvement. And I haven't personally designed a large trial. I've only created a small trial here, but like it's a complicated process, right? And I think that often people start off with good intentions, but the system like beats them. Because you need to get funding and you need to go through so many steps. So the aim is not to point fingers at particular people, but the aim is to like generate discussion so we can change the system and make it better for our patients, because they deserve that for us. Like, it's, as you mentioned earlier, like you'd want to enroll your mom or your dad if they had myeloma in this trial. And then one thing which like, I think is very important for us to highlight is this is not unique to myeloma. Like this hasn't been looked at specifically for other cancers, but if you and I were to do that, we would find the same findings. We'd find that in renal cell cancer, we'd find that in lung cancer, as you pointed out recently, where like crizotinib keeps getting used repeatedly. It's like, or chlorambucil for CLL for like years. So it's a recurring problem. And then, then we get these results and then we don't know what to do with them, or they're not applicable to our patients. So it's just a complicated.
Well, let me push on some of these things. I mean, the one irony of the Boston trial is that no self-respecting oncologist in Boston would have put patients on the control arm. It's misnamed. It should be called, I don't know. It should be called the, I don't know what country where that was an acceptable standard of care, but it certainly wasn't Boston, the city of Boston. The other point I always want to make is that these trials inform no nation. What do I mean by that? You might say, well, for the nation where VD is the standard of care, where bortezomib dex is the standard of care, well, now, selinexor, bortezomib dex is superior. Well, I'm sorry, if you're in a place where you have to give bortezomib dex because you can't afford lenalidomide or DARA, you're certainly not going to be able to afford selinexor. So these trial results don't help you there because this drug is just as unaffordable as the drugs you already can't afford, nor does it help us here because this isn't how we treat patients in this country. So it helps no nation. I always want to point that out.
That is so true. And we're going to have another paper coming out soon which sort of talks about post-protocol therapies, and like that's the messed up part, right? Because after the trial ends, like the control arm doesn't really get the intervention, and
you can't say too much about it. That's also embargoed.
Exactly. It's a complicated discussion.
Come back, we'll do another segment on that. But that's another.
But I guess the one really important point which I really want to highlight is like, so like, advocates will be like, so like, if people want to use DARA upfront, right? And like, so people in the United States are going to say, oh, adding daratumumab upfront shows us overall survival benefit. But that data is from countries where people don't get daratumumab upon progression. So they'll get it frontline as part of the trial, and they won't get it.
Wait,
so,
and that trial, you're talking about Maya? That's DARA RD versus RD.
So the one I've strong, so Maya, so far it also seems that the control arm has not been getting DARA at first relapse.
Exactly. Yeah. Okay.
About Alcyone, which is DARA VMP versus VMP.
I see. Okay, go on. Yeah.
Which already has an OS benefit, by the way.
Yes.
only
Okay.
10% of the patients in the control arm got daratumumab at
And if you can afford DARA VMP, why aren't you giving VRD?
That's a totally different debate. I agree. But yeah, so we're sort of like, yeah, that's another topic we're working on. But yeah, it's a mess.
Well, this feeds into what my third point was going to be, called, which I've written here on this piece, in this napkin that I'm writing on, does not speed. What do I mean to say? Proponents of these randomized controlled trials that do not inform the US nor global settings, their argument is that we need to do these studies to speed drug availability to patients. We have to run a straw man comparator arm because that gets a fast result so we can move the drug up accordingly. But the point I want to make is, I believe in almost all of these instances, these drugs were initially made available based on response rate. The very first time the drug was approved, it was because it generated a response rate. That's true for DARA. That's even true for selinexor, even, the STORM data, which, we can talk about, we can be critical of that, but it was true for these drugs. Once the FDA has approved the drug in the multiply relapse setting based on a response rate, you already have a path to the drug. Every subsequent randomized controlled trial has to ask the question, when in the sequence of therapies is it better to give this drug? Where does it add value? And if you're running those trials with control arms that are not what you would give otherwise, you don't really answer the question. Like, I really don't know. I mean, we can have this discussion, honest discussion, which is like, there certainly is going to someday be a patient where we think selinexor is a reasonable choice.
Sure.
But where? Who? We don't know. We have no idea who that person is.
Yeah, no, I completely agree. And like, so the problem is that Karyopharm is now designing a trial where they're going to compare selinexor Pomdex versus Pomdex. And again, that doesn't help us because we don't use Pomdex unless patients are really frail. So like, honestly, even if they were to use, and I just tweeted about this today, even if you were to use cyclophosphamide Pomdex versus, selinexor Pomdex, even that would generate a lot more meaningful information. Because cyclophosphamide has activity, it's underutilized, it's cheap. Like, I mean, if nothing else, just compare it with that. Like,
yeah, but I think selinexor Pomdex would lose to cyclophosphamide Pomdex. I think that's what they worry about. But exactly. That's important to know.
Yeah, and then another thing, this is my impression is, how bold the company is in designing trials speaks to how confident they are about their drug. And so if you look at belantamab, okay. So, and again, it's a bigger, I think belantamab is made by GSK and they have a lot more money, but so they're comparing, at first relapse, they're comparing DARA Velcade Dex versus belantamab Velcade Dex. So they're going big, it tells you that they have confidence in their drug, that even if it fails, they would have tried. And if it actually succeeds, then yeah, we'll use belantamab, earlier. So like, it just speaks to how how confident they are about their own drug working. All of the trials, I'm so sorry I interrupted you. All of their drugs, like even if they do compare to Pomdex, they compare a single drug or a doublet to Pomdex. Nowadays, we're not comparing triplets to Pomdex anymore, right? Yeah. Like even belantamab has a trial against Pomdex, and that's belantamab versus Pomdex. The new trial for 11-14 myeloma, that's venetoclax Dex versus Pomdex. Like, what is a triplet versus doublet, with a Pomdex as a control going to tell us? It's really useless, and it's a disservice to our patients. I don't know how I could ethically in the United States give a fit patient Pomdex, knowing it's been, I guess, like a 4-month PFS on average. It's a travesty.
DARA Velcade Dex versus belantamab mafodotin Velcade Dex. I like it. The only thing that's going to give me pause is if I learn that 70% of the people in frontline got DARA RD. That's the only thing that's going to give me pause. However, it's still better than some of these other trials. Let's be honest. Let me just pick your brain a second. Let's see if we're on the same wavelength. You've got a new myeloma patient in your clinic. Let's say they're, 78, truly transplant ineligible. What frontline regimen, you want to know their cytogenetics or not? Or does it even matter to you? What frontline regimen are you going to give him?
Well, if they're 78 and if they're frail.
Let's say they're not frail. Let's say they're hardy, but they're not transplant eligible.
Yeah, that's a good question. So I guess,
or start with they're frail. They're frail. You can take that.
So I will say, so we don't have randomized data that compares DRD versus VRD. All right, so that's DARA Revlimid Dex versus Velcade Revlimid Dex. Now, again, we don't have randomized data that compares these head to head, but if you do take a fine look at each of the trials and you compare the populations and you compare the toxicity profile for an old, frail patient, I do think that that is one instance where giving daratumumab upfront, and not as part of a cohort, but as DARA Revlimid Dex based on the Maya trial, I think that is a situation where I would use it. And that's because we have data that, neuropathy is pretty bad, right? Like you want to avoid neuropathy. There's some newer data out there that patients receiving Velcade are more likely to fall, and they have adverse events as a result. So that is one situation, yes, where I'll probably feel it's justified, the costs and all of the other factors, to give maybe DRD. But for all other things, I think like we have no strong convincing evidence that anything is better than VRD.
Yes. Okay.
We have there's and like there's all these implications where if you use daratumumab up front, then at the first relapse you don't have daratumumab in your pocket anymore. And
yeah, that's what I think.
And there are people who can we can debate about this endlessly. There's a lot of there's a big school of thought with good reason that the first treatment you have is when you're going to get the best remission and the only chance at a cure, because there are 10 to 15% of patients that are cured, right? By cure, meaning their disease doesn't come back. And that's the only way we achieve that is with a transplant as of right now. Like nothing beats melphalan 200, So there are people that, that will say, and they have some justifications, that the first treatment you have is your best shot at it. But I will say that overall, I'm hesitant to use, DVRD until we get more data, until we get overall survival data
with appropriate crossover.
With appropriate crossover, yeah. That's correct. And then Griffin it's a very excellent proof of concept, but it's a small study with endpoint of SCR, right? It's not powered for MRD, it's not powered for OS. So that's the one situation. For an old frail patient, I do think DRD will probably be more tolerable. Is it better? I don't know.
I don't know that for sure. Yeah. And I wonder where this literature on falls is coming from. But okay, I see your point. Yeah. I guess okay, but let's say we both agree on one thing. VRD, most people are getting that for initial treatment. VRD upfront. And it sounds like you lean towards auto and CR1. You lean that way for the person who can take it. Even that is debated on, the Michelle et al. Data, the CLGB study. We could talk about that another, but that's going to be a long conversation. Let's put that aside. Then in relapse, let's say you give them VRD. Majority of your patients are getting VRD. You're going to put them on Revlimid maintenance after their auto. They relapse, and then now you're thinking of a daratumumab containing regimen.
For sure.
Okay, me too. That's where we are. Carfilzomib frontline, veto for me. I need more data to be persuaded that it has a role in the frontline setting.
There's weak data. It's all weak data where some people they'll stratify for high risk cytogenetics. They'll use carfilzomib Revdex as opposed to Velcade Revdex, which it isn't really strong data, but there are schools of thought that will use KRD for high risk myeloma.
Ixazomib maintenance instead of Revlimid maintenance. That's another example of a control arm that's beneath the standard of care, huh?
That's correct. The bulk of that trial was enrolled, and that in the United States after we already knew that Revlimid prolonged survival, and that trial has shown a PFS benefit, but we don't have an OS benefit yet. So it's not even approved from a regulatory standpoint. The one good thing about the FDA is, at least for maintenance for myeloma, they want a OS benefit before they give approval. So kudos to them for that. At least they're keeping the bar high for that one.
Yeah, but don't worry, the NCCN will help them out there. And then if your patient is 414 post auto, are you going to do Velcade Revlimid maintenance?
So I believe, and that's the standard of care, is that you should have a PI as part of your maintenance.
Mm-hmm. Based on what?
So based on weak data, again, data. The most widely quoted data is the Emory experience by Ajay Nuka, and again that's like a 45, 50 patients, and they had excellent PFS. That was triplet maintenance, like VRD maintenance. I think most people are comfortable dropping the Dex. Giving Dex for a period of years is pretty toxic and hurts quality of life. But I will say that yes, most people would give, and I do think, again, again, the data is not like super strong, but the biology and all, like it kind of makes sense, like for 414 having PI on board as a maintenance strategy. But I'll admit that we don't have randomized data that it's better than lenalidomide maintenance.
Yes, and that's I just want that admission on the record.
I do, yeah.
Okay, so I know our time is almost up, and I have to skedaddle. But okay, let me summarize, and then let me see if you have anything to add. The summary is new paper out now, Lancet Hematology. Manni has taken the lead on this, and we're looking at control arm quality and randomized control trials of multiple myeloma. We discover that many studies are using suboptimal control arms at the start. Many more are using suboptimal control arms along the way. This is the study we did that little bit on authors.
Oh yeah, I was gonna bring that part because that was the
Okay.
one part we hadn't discussed. But yeah.
Yeah. Let's talk about that. So this was something that I peppered you to do, pushed you a little bit to do this. Okay, so what did you find with the authors?
Yeah, so it's fascinating, right? So about 75% of the time, there was an overlap in the authors, and like the vast majority of the time, the first or the last author of the previous study that had proven inferiority was the same first or last author that designed this new trial. So yeah, that's
Let me just emphasize that to the listeners why that matters so much. I mean, you can't say you didn't know these other results when you are the author of the other results. What are you talking about? You knew it was coming. You knew it was coming, and yet this is still the control arm. Oh, that's a dagger.
Yeah, it's frustrating, and yeah, I mean, it just highlights the need for improvement, for better processes, for reform of the FDA, because we often use this as an excuse, right? We're like, oh, the FDA like allowed this control arm, we like hide behind the FDA.
Yeah.
Yeah, so I think the entire system needs reform.
It's always like, yeah, I think that is often used as an excuse. Or sometimes they push it even further. They say the FDA told me to do this. I was like, no, that's not what they did. The FDA allowed you to get away with this, and you seized them on that opportunity.
Yeah.
Manni, this is a paper that I think people, they should really read. It was an exhaustive effort. It's out now in Lancet Hematology, control arm quality, overlapping authors, a lot of really important issues to grapple with in oncology. No matter how you feel on this topic, I think we all have to grapple with these issues. You'll be back to talk more because we're going to look into post-protocol care. We're going to look at a whole bunch of other issues. And you will be back. You'll be back for more installments. And eventually we'll make myeloma great again.
No, thank you for having me. I really enjoyed this.
Thanks for doing it.
Thank you.